Good morning. Am I audible to everyone? Please say yes if I'm audible. Right. So today class is about the deep neck spaces. This seems to be very difficult, but it's very simple. I'll show you how. First of all, the anatomy. Because if you know the anatomy, then you can easily understand where are the what all infections can be present with deep neck spaces and what are the presenting features and what could be the modalities of treatment. So first of all is anatomy. So first is fascia. Just simple fascia first, then we will discuss about the deep neck spaces boundaries, and then third is deep neck space infection last. Basically, these are not three things, these are actually one and the same things. First, fascia, you will now come to know how. Very simple, there are two types of fascia in neck. First is superficial, other one is deep. First is superficial, other one is deep, and deep is further classified into three types: superficial, middle and deep. सब देख लो ना, लिखना क्यों? तुम्हारे पास ही तो नहीं, कुछ अलग हो तो लिखो. So deep can be further classified into three parts: superficial, middle and deep. As you all know, in neck, if you palpate below the skin, first muscle is platysma. Okay. First muscle that will come into the point is platysma. Then there will be a layer of strap muscles that is between the midline muscles from the sternum to the hyoid bone, thyroid cartilage and neck and mandible. These are the strap muscles, central muscles. If you see here, this small line, this very thin line, that is actually platysma muscle. It actually just present just below the skin. And this is the first layer. Then there are muscles in the same layer. This is sternocleidomastoid. These are the strap muscles. And these are the trapezius muscles. They are other things. So first of all is platysma. So first layer that is present between the skin and the platysma is superficial fascia. Okay. That is superficial fascia. All other layer of fascia present below this platysma muscle is deep fascia. So the superficial fascia lies between platysma and the skin. And there are vessels that traverse this fascia through the platysma muscle, through the platysma, through this fascia into skin. So whenever we do the surgery, we elevate the skin. That will be a subplatysmal flap. We elevate the platysma also along with the skin so that there is no vascular compromise of the skin. Otherwise, they may go into necrosis. So always when we do the surgery, first of all, we give an incision over the skin. That should include the skin as well as the platysma. We should try to elevate the platysma also along with the skin. That is the reason for the vascular viability of the skin, the pedal. Okay, that is the superficial fascia. Then comes the deep fascia. Deep fascia can be categorized into three parts: 1, 2 and 3. That is superficial, middle and deep. Superficial, there is a layer that includes this is the sternocleidomastoid muscle. Then there are strap muscles. Then these are the muscles like omohyoid muscles. Omohyoid muscles, these are sternocleidomastoid on both sides. Then there are trapezius muscles. So these all muscles, all these muscles, these are the trapezius muscles back. They all are covered in layer of fascia that is known as superficial layer of deep cervical fascia. That red line, this red line is all superficial layer of deep cervical fascia. Then this blue line, there is a layer of there is extension of this fascia which encloses the carotid vessels on both sides. You can see this carotid artery, carotid vein, and vagus nerve. These are the vessels. There is a fascia which cover all these layers. This is an extension of actually superficial layer of deep cervical fascia. You can see this is also red, somewhat red. Then this blue is middle layer of deep cervical fascia. This middle layer of deep cervical fascia actually is it encloses the other layer of neck, that includes the thyroid gland, then around the trachea there is the fascia which connects the posterior layer of trachea, thyroid with the trachea. It consists to form the which ligament? Barry's ligament. Very hard to dissect. Okay. Then there is a layer of fascia that is present, which includes this thing, thyroid cartilage, trachea. Then there is a third layer. You can see this orange layer, which covers the vertebral muscles in front. These are vertebral muscles, no? So this layer which covers the vertebral muscles in front and vertebral muscles in front. This is actually the deep layer of cervical fascia. Okay, so this is regarding the so that is regarding the three layers: superficial, deep, and the other layer of deep cervical fascia. Superficial, middle, deep. Okay, got it. Then superficial layer, I have already discussed this thing. Superior attachment is by the zygomatic process in front. Inferior attachment to the thorax and axilla, similar to subcutaneous tissue. And in sheath is a platysma and muscles of facial expression. And marginal mandibular lies deep to it. This is the superficial layer of deep cervical. That was superficial. Then this is the deep cervical fascia, of which the superficial component is. It completely surrounds the neck from skull to chest, and arises from the spinous process, ligamentum. Okay, superior border is by all these lines: skull base, zygoma, mandible. Inferior border is by scapula, clavicle, and manubrium, and it splits at mandible and covers the masseter laterally and the middle surface of middle pterygoid. And envelops the sternocleidomastoid, trapezius, glands, parotid, and it forms the floor of the submandibular space. This is the important thing. It forms the floor of the submandibular space. And all these muscles, sternocleidomastoid, trapezius, submandibular glands, and parotid, it envelops by the superficial layer of deep cervical fascia. This is the layer. As you can all see, this layer, which is a continuum from the face, it first covers the deep cervical fascia. It encloses. Outer layer becomes very, very thick. Very thick. This layer is very thick. When it splits to enclose the parotid fascia, superficial deep cervical fascia, outer layer becomes very thick. That's why any abscess or an inflammation of the parotid, it bulges out laterally very late, or it will be very slight as compared to the other areas. And then it goes into the neck and it covers the gland, it covers the muscles, everything. Similarly here. And from it extends from the zygomatic process. This is the area of zygomatic process. This is the area of zygomatic process, ligamentum, goes into the thorax and axilla. This is the extension of the superficial layer of deep cervical fascia. As you can all see. Then there is a middle layer. Middle layer basically, this is all thing to learn from where does it arise. It arises from the superior border is from the hyoid and thyroid cartilage, posteriorly from the skull base. Inferior border is, it continues with the fibrous pericardium in the upper mediastinum. So it covers the visual buccopharyngeal, name of the portion that covers the pharyngeal constrictor buccal muscle. Basically, it envelops the thyroid gland, trachea, esophagus, pharynx, and larynx. This is all covered by the middle layer of deep cervical fascia. And this fascia extends up to the pericardium, continues with the fibrous pericardium in the upper mediastinum. And in muscles which is covered are hyoid and thyroid cartilage. Inferior, this muscular division is there by the superior border is by hyoid and thyroid cartilage. Inferior border of sternum clavicle envelopes infrahyoid strap muscles. There is a group of muscles infrahyoid. Strap muscles are covered by the middle layer of deep cervical fascia. This is the middle layer of deep cervical fascia already discussed. Then deep layer, basically most of the origin is usually same, that is spinous muscle ligamentum nuclei. It lies deep to the trapezius. It basically forms the facial carpet of the posterior triangle. So the floor of the submandibular triangle is formed by the superficial layer of deep cervical fascia, while the floor of the posterior triangle is formed by the deep layer of deep cervical fascia. And it fractured outward sleeve along the brachial plexus and axillary vessels. Basically, this is basically it basically covers the vertebral muscles and deep muscles of the neck. There is a two layer of this, alar layer and prevertebral layer. And prevertebral layer is basically covers the vertebral muscle. Over this fascia, usually the larynx, pharynx, and all this esophagus, this glides over this vertebral muscles. As you can you can hold off your larynx, and you can basically move this larynx laterally and side by side. That is because this deep layer and the middle layer, which covers the larynx and esophagus, they basically glides over each other. This is the reason. This is a deep layer. As you can all see, this is the layer which covers the prevertebral muscle. It basically here at this area, basically it covers all the deep muscles of the neck, prevertebral muscles. But at this area, it basically splits into two. Posterior part is the prevertebral layer, and anterior part is alar layer. These both layers are actually part of the deep layer of deep cervical fascia. But in reality, actually, this is also a space. This is also a space, and this is also a space which I will discuss in detail in the next slides, from which infection can travel down to the thorax. And in between this alar layer and the esophagus, there is a space, that is the middle layer which covers the esophagus, and alar layer. There is also a space which is actually retropharyngeal space. We'll discuss in detail. So there are actually two spaces. One space is between the middle layer which covers the esophagus and larynx, and between the alar layer. One space in between the alar layer and the prevertebral layer of cervical fascia. There is one more space that lies between the prevertebral fascia and the prevertebral muscle. So basically, small area, it contains three spaces. Got it? The small area which covers three spaces between this fascia. All have different relevance, different prognosis. Here also you can see there are different lines, different areas. Okay. Carotid sheath. Carotid sheath is also known as Lincoln highway. I have told you that this carotid vessel, they are covered by a fascia which is actually an extension of the superficial layer of deep cervical fascia from the sternocleidomastoid and all these strap muscles. So basically usually it is formed by all three layers, but anatomically it is actually an extension of the superficial layer. It is basically a separate space. It becomes a space in its space. It is a separate space. Anatomically, it's separate from all three layers. It contains all these vessels. It is actually known as Lincoln highway. It is known as Lincoln highway. It basically extends from the skull base to the thorax. Okay. At the level of clavicle, it fuses with the covering of the great vessel at the root of the neck and pericardium. Basically, if there is any space, any problem in this area, it can goes down to the pericardium, mediastinum. This is known as Lincoln highway. So, Deep neck spaces, actually it extends into the, it can be described in relation to height usually. There are spaces which are actually extends all along the neck, then it can be supra height or can be infra height, depending on the type of spaces. So first we'll discuss about the spaces which traverse the entire length of the neck. That is known as superficial space. Superficial space is between the platysma and the fascia which covers the platysma. That is between the superficial fascia and the platysma muscle. It surrounds actually platysma. It contains tissue, node, nerves, and vessels. Subplatysmal flaps. That is why we elevate, because we need to maintain this area, because the vessels it traverse from the through this fascia into the through this space into the skin. So whenever there is a problem, there is superficial abscess will be there, and we can just do the IND and we give antibiotics and that get resolved. Then there is a retropharyngeal space. I already discussed in detail. This is an area. This is the middle layer of deep cervical fascia, that green line. And actually this is also a buccopharyngeal fascia. So anterior border is buccopharyngeal fascia, which is this fascia. This green line, buccopharyngeal fascia, which is basically fascia which covers the pharynx and esophagus in posterior part. It is actually, they have given the name, but actually it is attached to the middle layer of deep cervical fascia. This is the blue line is middle layer of deep cervical fascia. It is one and the same thing, but there is a separate name for specific this portion of this fascia, that is known as buccopharyngeal face. And between this green line and this first red line, that is the alar fascia. Because we have, I told you, this deep layer can be converted, has been split into two parts, alar front and prevertebral posteriorly. So posterior border is alar layer of deep fascia. So inferior border is T4. Basically, this space, it extends up to T4. So if there is any infection, it has a potential to go up to the T4. This is the retropharyngeal space between the green line and first red line. Basically, it mainly contains the retropharyngeal nodes. There is a raphe that is known as spacogeria, that is not very important. But the main content which can get present is there are nothing except few retropharyngeal lymph nodes which are present. So if there is infection of this area, these nodes can be ruptured because of the pus. This is the area, reddish space. This is the vertical section. Now comes the which space? This is the danger space. There is a danger space. Danger space is basically between the two layer of deep cervical fascia, that is between the alar layer and the prevertebral layer. This red area is danger space. It extends up to the diaphragm. See, retropharyngeal up to T4 and this space up to diaphragm. It basically, this space contains the nodes. This contains only loose areolar tissue. This is between the alar fascia and the retropharyngeal fascia. Alar fascia and between the prevertebral fascia. This is also known as dangerous space because potential of this space infection can extend up to the chest, leading to mediastinitis, pericarditis, and patient can actually die sometimes until you treat the patient vigorously. Okay, that is the danger space. Then come the prevertebral space, that is between the prevertebral fascia and the muscles. It basically extends more down up to the sacrum. Sacrum or coccyx sometimes. So basically it extends along entire length of vertebral column. So this first space T4, second space diaphragm, and third space up to sacrum. Sacrum up to sacrum. This is the red area. This is known as prevertebral space. Every space has different implications for the patient. Then there are vascular spaces. This is known as Lincoln highway. Lincoln highway is basically the infection that surrounds the carotid vessels. It can become actually secondly involved with any other deep neck space infection by direct spread. Basically, we have actually divided these spaces in different spaces. But more or less, except superficial fascia, or in fact superficial fascia also, all this fascia, all these spaces of deep neck spaces, all actually they are in continuity more or less. So any one infection in any space, they can actually go and involve the other spaces as well after a certain period of time. Then there are few spaces like submandibular space. Then there comes the pharyngomaxillary space. We'll first discuss submandibular space. It is basically submandibular space is a suprahyoid compartment. It contains two parts. Basically, there are two areas, sublingual and submaxillary, and there is a layer of muscle that is the mylohyoid muscles. Above it is sublingual space, and below it is submaxillary space. So sublingual space and submaxillary space. It contains sublingual space contain areolar tissue, hypoglossal lingual nerve, sublingual gland, Wharton's duct, and submaxillary space contains these muscles as well as gland. This is the muscle area. This is actually different area. And there is very important muscle spaces, that is pharyngomaxillary space, that is known as parapharyngeal space. Very common infection, mostly infection of a patient, they come to us is basically Ludwig's angina or parapharyngeal space infection. There are different names for this: lateral pharyngeal, peripharyngeal, pharyngomaxillary, pterygopharyngeal, pterygomandibular, pharyngomastecatory. But you should remember only one name, that is parapharyngeal space. This is a pyramidal shape. It is a pyramidal shape because apex is wide and base is wide and apex is narrow, giving a shape of pyramidal shape because it starts superiorly by the skull base, at the area of skull base where it is wide, and inferiorly at the area of hyoid bone it becomes narrow and tapers. Posteriorly it is covered by the prevertebral fascia, medially by the buccopharyngeal fascia. Very difficult to imagine 3D, but you have to make a 3D picture in your mind. So medially it is by the buccopharyngeal fascia, and laterally by the middle pterygoid, mandible and parotid. This is a 3D picture. So in medial side there is superior constrictor. Superior constrictor is basically a muscle of the pharynx. Then comes the tonsil, superior constrictor, and laterally it is by the pterygoid muscles at the junction of mandible. So mandible, pterygoids, pterygoids basically insert over the mandible. So it is the idea the mandible, diploparotid, and mandible, diploparotid, and pterygoids. They form the lateral part, and medial part is by the soft palate, superior constrictor, and tonsil up to hyoid bone from skull base, and posteriorly is by the prevertebral fascia. This is a space. This is a potential space which can get infected. This is the idea. You might find it difficult to understand. Basically, in this space, there is a bony projection known as styloid. So if there is infection in front of styloid, that is known as pre-styloid. In styloid, behind the styloid, it is known as post-styloid. The relevance is, as you can see this is red area is known as styloid process. This is potential space. As you can see, suppose this is mouth cavity. This is all our middle part. That is known as superior constrictor and tonsils and everything. Lately, this is parotid gland. These are the mandible. This is the pterygoid muscles attaching medial and lateral pterygoid and middle pterygoids. This is along the mandible. There is a parotid gland. So basically, this is a space in between these 2 points. In the center, there is a thing called red line is styloid process. So any infection behind the styloid is a post-styloid, and in front ahead of styloid there is no pre-styloid. So basically, this is the post-styloid area, which contains all these things: carotid sheath, nerves, vessels. All main things are in the post-styloid compartment, and in pre-styloid compartment there are muscles, there are fat, connective tissue, lingual nerve, alveolar nerve. All these things are basically nerves and lymph nodes are present in pre-styloid compartment. In post-styloid compartment, there are vessels, actually, great vessels. So what happens is, in How do we define the infection in CT scan? At the center of this area, there is a layer of fatty tissue present. Fatty tissue present. So if there is infection in the pre-stereo compartment, that will push this fat posteriorly and medially. And if there is a infection in the posterior compartment, it will push this fat anteriorly. So that is how we divide or we characterize the infection, site of infection in a parapharyngeal space. It communicates with several deep spaces because it communicates with retropharyngeal spaces behind, peritonsillar through the superior constrictor, masticator space, parotid space, and peritonsillar space. This is the thing. As you can see, this green area, this is the parapharyngeal space. In front, that is known as, which is this thing? क्या होगा भाई बताओ? All these spaces, you can see this. This is a parotid space, a mandibular, parotid. This is a mandibular space. All these spaces, if there is an infection over here, it can go all along this thing. Suppose this is a masticator muscles. So masticator muscles, and this is a gland. It can go and involve all these things. Posteriorly, parapharyngeal space is communicated with the retropharyngeal space. Then there is a peritonsillar space. There is a infection called quinsy, which present actually in this area. You can see between this tonsil, then there is a superior constrictor muscle. There is a tonsil presence, lateral tonsil, there is a superior constrictor muscles. So the space in between this, both of these, this is known as peritonsillar space. Infection of this space can lead to the condition known as quinsy. So, and the superior constrictor muscle is communicated with is a boundary of parapharyngeal space. So basically, if there is infection of this area, it can go through this and can communicate with the parapharyngeal space at some point of time if it's not treated well. This is the area. Then there's a parotid space. I told you parotid space. It is basically space the fascia which splits and involves the parotid gland. So it is also communicated with the parapharyngeal spaces. Superficial fascia, it splits and forms the two-layer middle and lateral of the parotid gland. This is known as parotid space. Masticator and temporal, I should not go into deep into this. It will become more complicated. So these are about some spaces. So for yours, this thing, there are 3-4 spaces which are very important. First is retropharyngeal space, then there comes the submandibular region, then comes the parapharyngeal spaces, and then fourth is quinsy, which is important at undergraduate level, very important. And this is actually, these are the most common max spaces infection. So whenever there is infection, so now we are clear with the anatomy. Now we are clear with the anatomy, and now we will discuss about if there is a pus over this area. We will discuss first about the etiology of infection, then we will come about the microbiology, clinical manifestations, some specific infections, and then the last is complications. The first is, so as we all know that this is the very old infection. In pre-antibiotic era, 75% of the infection are from the pharynx and the tonsil, because now we treat the pharyngitis and tonsillitis very well with the antibiotics, but it was not a case when it was in the pre-antibiotic era. So most common reason is dental infections, which are the major source of all these infections. Then comes the peritonsillar cellulitis, then comes the upper GI trauma, retropharyngeal lymphadenitis, Port's disease, that is the cervical tuberculosis, then salidonitis like submandibular gland or parotid gland infection. From temporal bone, if there is infection from the CSOM, that pus has gone into the submandibular fascia, that is known as substernocleidomastoid muscles around the fascia, that is Bizold abscess, Patras apex infection. Then there are some rare things, congenital cyst, fistulas, intravenous drug abuse. So the pre-antibiotic era most common source of infection was Staph aureus, but now it is the actually alpha hemolytic streptococci which is more common. Then comes the Staph aureus, and there is a good number of anaerobes also which are very responsible for all these infections. Gram negative are usually uncommon. Almost always it is polymicrobial, not a single bacteria which is mostly responsible. So the clinical manifestation the present with first is pain, which is a very initial constant feature, which is an indication of either extension or resolution. If pain starts increasing, there is an extension. If it is pain is decreasing, that is a resolution. Exception is the retrovaginal abscess in children. Fever will always be present because if there is a pus, there is infection, there will be fever also. There will be initial spike followed by elevated temperature, spiking temperature, doubt sept. If there is if there is spiking temperature, that is temperature is increasing fast with chills and rigors, we should doubt septicemia, septic thrombophlebitis of the internal jugular vein, or the extension of this infection into the mediastinum. There can be swelling, trismus, and limitation neck movement depending on site, because suppose the pterygoids are involved, there will be trismus. So pterygoids are involved usually in there is a usually which is involved in when there is due to swelling, like especially is peritonsillitis. Because of pain, trismus is patient will not be able to open the mouth. Then progressive dysphagia or rhinophagia, voice change, dyspnea, and chest pain. First and foremost is Ludwig angina. It was described by William Friedrich von Ludwig in 1836, when he said that gangrenous induration of the connective tissue of the neck, which advances to involve the tissue which cover the small muscles between the larynx and the floor of the mouth. That is what he said. So basically it is an infection of the submandibular space. Usually it is caused by the dental problem, dental caries, anterior teeth and first molar infection of sublingual space, and when it's the second and third molar, there is infection of the submaxillary space. So criteria for diagnosis is there is a rapid progressive cellulitis, not an abscess. Ludwig angina is cellulitis, develops along facial planes by direct spread and not by lymphatic spread. It doesn't involve the gland or lymph nodes. It involves both the sublingual and submaxillary space, and they are usually bilateral. In initial phase they could be unilateral, but they at the time of presentation they are usually bilateral. There is one term called pseudo Ludwig angina, that is other inflammatory condition which involves the floor of the mouth, limited infections involving only sublingual space, submandibular lymph nodes, submandibular gland, submandibular space or abscess involving one or more of these spaces. So basically it is an inflammatory cellulitis of the submandibular area. You can see this picture. So mainly it is by the dental cause or sometimes by the periodontic injury or mandibular fractures. Clinical, this is the photo. You can see this photograph. There is a great induration, as you can see. There is a bulge over the floor of the mouth and tongue. There is a, when you see the patient with the induration and thickening, patient is toxic, and on oral cavity examination, you will see that the floor of the mouth is elevated, with tongue is also elevated. It is a condition that is known as Ludwig angina. On getting an X-ray, you can see the soft tissue edema all along the floor of the mouth, along the neck. And the most common complication is respiratory obstruction due to the laryngeal edema that can be present. So either you should be very, very quick in analyzing whether the patient needs tracheostomy or not. If possible, do the tracheostomy, otherwise intubation, whatever. We need to maintain the airway, and you should anticipate this complication as early as possible. So clinical features are basically young people with poor dentition, increasing oral neck pain and swelling, increasing edema and duration of the perimandibular region, floor of the mouth. There will be thrusting of tongue posteriorly and superiorly. There will be neck rigidity, trismus, rhinophagia, and fever. Don't confuse neck rigidity meningitis. This is a different thing. There will be dyspnea and stridor, which is most commonly present, most common complication. Fever will be there. So what is the treatment is antibiotics. as most common is streptococcus, which the cold standard is penicillin, and for anaerobes it is metronidazole, followed by extension of the source of infection, that is the tooth if it is present, and any other foreign body if it is present. Late stages by the airway, we need to do the tracheostomy, and surgery is by the, we should give a horizontal incision with wide exposure. Tissue have peculiar salt pork appearance with woody induration, watery edema, and there is a little edema bleeding. Gross purulence is rare because this is basically cellulitis. Cellulitis, multiple drains and wound kept open. So we need to give antibiotics. We need to give a long incision, adequate exposure, and then tracheostomy for airway. This thing. That is about the Ludwig angina. Paraphageal abscess. You can see in this paraphageal abscess, I told you that the middle border is superior constrictor, as you can see this. So when there is a pus in this area, edema in this area, it will push the superior constrictor, thereby pushing the tonsil. Thereby pushing the tonsil. So the tonsil will be pushed. As you can see this, as this is not an area of infection, the mucosa over the tonsil is absolutely normal, and this is this uvula. Uvula is absolutely normal. It is not edematous, because we sometimes there is a confusion about the quinsy and the paraphageal space infection. In quinsy, there is reddishness, there is edema over this area. Moreover, this uvula is red and edematous. While in paraphageal space, mucosa is normal. You can see this fine red, the fine vascular lines, and normal mucosal layer color of the uvula, which is usually not present when quinsy is present. So edema, tonsil will be pushed. So causes will maybe because of peritonsil abscess, dental infection from other space. Clinical features, there are two compartments: the anterior compartment, that is pre-styloid, and posterior compartment, that is post-styloid. So in anterior compartment, that is pre-styloid process infection, what are the clinical features? The clinical features is prolapse of the tonsil. There will be trismus because of the involvement of the pterygoid muscles. External swellings behind angle of jaw and rhinophagia fever. While in posterior compartment, bulge of lateral pharyngeal wall behind the tonsil, because that is behind, the postulate is the behind the tonsil. Lower canal paralysis because of involvement of the jugular foramen, jugular this thing. Horner syndrome because sympathetic chain is present, swelling of the parotid region, and rhinophagia and fever. This is the area. This is the pre-styloid. This is the post-styloid. So treatment is, it is IV antibiotic, that is must. Surgery should always be done through the external approach, not through the internal approach. We should never try to drain this abscess through the intraoral approach, because of the complication, like you may injure the carotid vessels and some other bleeding, which is because you have very little space to do the control. While in external approach, you have enough space, you are more safe, and there are two types where we should give an incision, that is 1.25 centimeter below the angle of mandible, because marginal mandibular nerve, it traverses at this area. So if you give us incision 1.25 centimeter below the ramus of mandible, you are safe. You are not going to injure the carotid vessel. You can open it, you have a wide exposure, you can drain the abscess, be it pre-styloid, be it post-styloid. This is a T-shape incision, or transverse also can be given. T-shape and transverse, but transverse part will always be by the 1.25 centimeter below the angle of mandible, below the ramus of mandible, body of mandible. So this is the regarding the drainage of the parapharyngeal space, parapharyngeal abscess. Retropharyngeal, same thing. Retropharyngeal space I have already discussed in detail. The main reason is in pediatric and adult is a different thing. In pediatric, it is basically the separation in the lymph nodes, because of the adenoids and tonsil infection can travel to the retropharyngeal node, and they may rupture after the formation of pus, leading to the formation of retropharyngeal abscess. And the adults, it is basically because of the trauma, instrumentation, extension of medullary deepness. And one more most common thing is port spine. In port spine also, patient may have retropharyngeal abscess. 50% basically in child it is present, and 96% occurs before the 6 years of age. In children, they may present fever, irritability, lymphadenopathy, torticollis, poor oral intake, sore throat, drooling. In adults, it is pain, dysphagia, or dinophagia, anorexia, dyspnea, respiratory distress. Lateral posterior oropharyngeal wall will be bulged. You can see in this picture. So how do we make a diagnosis? Best is CT scan. Yes, it is there, but the quick investigation of choice is X-ray, soft tissue, and lateral view. So there are different things, like at C2 it should be 7 millimeter, C6 for 14 millimeter, C6 for 22 millimeter, low cervical lordosis. See, this is cervical lordosis. It is straight. Usually there is a slightly curved. This lordosis lost is diagnostic. Technique is, so this is regarding the measurement, but sometimes you may not do this. So what we can do is, the main thing is that the bulge, the tissue present more than one half of the cervical body width. That is the diagnostic of retropharyngeal space. That is the rough, more than one half of the cervical body width, cervical spine width of this cervical vertebra width. So how do we drain it? Retropharyngeal abscess should be drained intraorally. Intraorally. This is the CT scan findings. We can see this is the trachea, then there is the esophagus. This is full of pus. That is the retropharyngeal abscess. So it should be first IV antibiotics and fluid replacement. Surgery is usually by intraoral approach. External can also be done. It can also be done. But this is the abscess which can be drained intraorally because of the safe features. Because parapharyngeal vessels are there, but this area there is no vessels, so we can drain it intraorally. Then the quinsy, which is where you can see in this area, tonsil is bulged, but you can see the mucosa is edematous, red, congested, and uvula is also congested. Basically, why this happens? Because the abscess is not in the pharyngeal space; it is between the tonsil and the superior constrictor muscles. So basically, it is causes extension of the tonsillitis or de novo, no idea. Clinical features is fever with chills and rigors or dinophagia, hot potato voice, halitosis, trismus, congested tonsil with edematous pillar. So treatment is by IV antibiotics and fluid. Surgical drainage is surgical drainage. We need to put a needle. And aspirate it, or we need to make an incision and drain the abscess. So what we can do is, what are the area? There are 2 points. One is between at the most fluctuant area. Other is anterior tonsillar pillar. Draw a line from anterior tonsillar pillar and a line at the base of uvula. The point where this 2 line meets, this area you can make a point of insertion of the needle, or you can put a nick and drain the abscess. Masticator space infection, same, no need to go into detail. So what are the complications? Complications are, all these spaces are airway obstruction. Airway obstruction, then for that you need, maybe you may require tracheostomy and endotracheal intubation. And this abscess may rupture and forms the pneumonia, lung abscess, and moreover, they can cause the pericarditis, mediastinitis, which is a potentially lethal complication. There is one more term called Lemire syndrome. Lemire syndrome, that patient may present, and this is a complication which usually been not detected in time because of the less exposure or inexperience, or you see what your mind knows. You may not anticipate this complication. What happens is, this is basically an internal jugular vein thrombophlebitis. It is basically caused by, it's known Lemire syndrome, caused by Fusobacterium necrophorum. Patient may present with high fever with chills and rigors, and there is swelling and pain along the sternocleidomastoids. The problem is there is a bacteremia, septic embolization, dural sinus thrombosis. Usually it is seen in IV drug abusers because they may accidentally put the needle into the jugular vein. The treatment is by IV antibiotics. Anticoagulation is controversial in that way. We prefer it, but some say it doesn't require, and we need to expose the vein. We need to ligate and excise the thrombus. That is the treatment of choice. Carotid rupture, it is very rare. And nowadays we never sees it because of the timely management. And other thing is, if it does happen, patient won't be able to come to us because the mortality rate is very high, and there is a very less time that patient can come to us. We have hardly seen carotid artery rupture because of all these things, very few, because the patient before this rupture, they may have central bleeds from ear, nose, and mouth, and they have majority from internal carotid, less from external carotid, and fewest from common carotid. Treatment is proximal and distal control, ligation, patching, or grafting, if at all happens. If at all you get the opportunity to treat the patient on time, because time is very less. As you know, carotid artery rupture will lead to the sudden death. Then there is a complication like mediastinitis. The mortality rate is very high, 40%. There is increased dyspnea, chest pain. Chest as X-ray, you will see widened mediastinum. Treatment is early recognition intervention. This is the most common thing. The purpose of my whole discussion is we should anticipate all this complication before this all happens. And the thing is early recognition and intervention, aggressive IV antibiotic therapy. Surgical drainage is usually by the transcervical approach or and in the neck from where this pus is coming, and the chest, we need to put the chest tube or thoracotomy, whatever is required. Cranial deficits, necrotized cervical fasciitis, osteomyelitis, and Grissel syndrome. That is the inflammatory torticollis causing cervical vertebral subluxation is the other complications. So there is special consideration like an airway protection. We should do the endoscopy or tracheostomy to secure the airway. If possible, do the intubation. If not at all, we should go for tracheostomy as early as possible. And we need to do the image guided aspiration if possible. Patient should be, if there is small abscess, limited extension, uniloculated. In these patients, instead of giving a incision and drainage, we can just take out this abscess through the image guided aspiration, that is the ultrasound guided aspiration. Advantages are early specimen collection, reduced expense, and avoidance of neck scar. That is regarding the all these things. So students, any doubts? This is an interesting topic, provided you have listened to this lecture. No doubts? Okay, thank you.